Good evening, everyone. Thank you for your attendance as members, and if anyone else is zooming in and viewing, you're all very, very welcome. Thank you for coming to this Health and Wellbeing Board meeting. I'd like to welcome the new members to this board. That's Dr. Aditi Shah, Dr. Mohan Sekram. I see his tweets many, many times. Thank you for your wonderful communication with your residents and your patients. Dr. Karen Worthington and Mark Creelman, who's covering for James Blythe's secondment. I don't think we've received any apologies for absence unless I'm to be corrected by Clarissa. Okay, thank you.
No apologies for absence.
Thank you, Clarissa. We'll take a few seconds to ask if there are any declarations of pecuniary interest. There being none, we can carry on to item 3, and that is the minutes of the previous meeting held on the 23rd of June 2020. And if there are any comments, I'm very happy to take those either now or offline via Clarissa, but certainly we need to see if we're happy to approve those minutes, which go to about 6 pages. Are there any dissenters to approving the minutes of our last meeting? Thank you. There have been no dissenters. Those minutes are approved. I'll move on to item 4. And we're going on to now our substantive discussions and reports. And I move towards Dagmar Zuna, our excellent Director of Public Health, and she will present the Situational Awareness Report. We're on item 4A. I just need to remind everyone that item 4C has been moved, if that is still the case, to just before item 6. So that gives Rob Clark a chance to be here. But certainly that'll be a flexible situation. But as of now, I'm very happy to hand over to Dagmar. Dagmar, over to you. I think Dagmar is frozen.
Sorry. Good afternoon. Can you hear me?
Yes, I can.
Excellent. Good afternoon and welcome everybody. If Clarissa could give me the slides. So I will initially share with you what we call our Situational Awareness Report. And just as a reminder, obviously as the Health and Wellbeing Board, we are an important part of the governance for our local outbreak control. And so for all of us members to have situational awareness where we are with our infection in Merton is really essential. And that's the purpose of sharing with you this item. Before I actually just home in into the main messages, I wanted to double check that all of you are receiving this report on a weekly basis. And I would also ask you, because obviously the report is evolving, we want to make it as useful as possible. So if you have any comments, do send them back to me, and I will try my best to take your ideas into consideration. So without further ado, if Clarissa gives me the next. So, sorry, there's always a little bit of a lag, so we need to work with that. That is probably the most important slide of the whole pack, and I will dwell on that one. And to your relief, I don't go through all the others. So this gives you the summary. And just as a reminder, our main early warning signs of how we are with the infection are our new cases, our infection rate per 100,000, obviously how many outbreaks we actually have got. We call them situations. And then very importantly as well, what is the positivity of the tests? So amongst all the tests, what is the percentage positive? Now you would think from the data here and from the little arrow on the right-hand side that actually the trend seems quite encouraging. I have to put a damper in, and a number of you will be aware that unfortunately we are not completely trusting in our data at the moment. And the reason why we're not completely trusting is also visible on this summary. We're also monitoring how many tests are taken regularly. And you will see that our numbers are actually going down. That is what worries us. And you will have heard in the press that at the moment, the national testing system struggles with laboratory capacity. That is now mirrored in what happens in Merton. So not enough tests are done. And therefore, we have to take our data with a pinch of salt. And because we're not 100% sure that we're picking up in all of the infections, what we've added in is under NHS data, you will see right at the bottom that we're monitoring anyway our 111 calls, and there you will spot that they have gone up quite a bit, and that is what also happens in London, and that made us aware and thinking probably not all is completely fine in Merton either. And relatively new, and I'm very grateful to our NHS colleagues, we are now also sharing inpatient data, because that is obviously the hardest of evidence that there is impact of COVID. And so far in Southwest London, we had 9 admissions. Good news at the moment is that we haven't got anything in ITU, but they have been creeping up, whereas over this summer we had none. Good news again, so far no increase in any death, but the bottom line of the summary situation at the moment is that we think, in comparison to the rest of London, Southwest London and Merton are steadily increasing, but we are increasing. And in the whole of London, the increase is steeper. And at the moment, we have to use a lot more indirect intelligence to be aware of the situation. So that's for you to be aware of. If Clarissa goes further to the other slides, as I said, please use them as a reference. I'm not dwelling on them. If we are going right to the last slide, which shows you the London situation, because as I said, Merton is not isolated. Merton is part of Southwest London as the sub-region and then of London. And as you can see from that slide very visually, is that the whole, in fact, of South London is at the moment slightly better than North London, and particularly North East London. Our colleagues in Redbridge and Newham have seen very steep increases. We think it's only a matter of time before we are in a similar situation in Merton. So that's a brief canter through our update. The situation update also tells you how many outbreaks we had. So we have had cases in schools. We've worked very closely with our schools team, with our head teachers. Rachel is obviously on the call as well. It was a pretty busy beginning of school, but by pulling together, we feel the support is working fine. We're keeping a really close eye on our care homes. Again, the whole care home testing is happening in Merton. There have been delays in terms of test results, but all in all, it is working. And we are picking up occasionally, particularly asymptomatic samples. We haven't had any symptomatic cases, touch wood, so far. So I stop here and just ask you whether there are any questions. on the situational awareness report. What I have to let you know is that obviously pulling the data together requires use of quite a number of data sources, and they have slightly differential lag periods. So the data is not always completely up to date. I always try to share with you the most up to date, but some eagle eyes of you might have spotted that on the slide the JBC level still says 3, but actually the national alert level has been increased to 4 now. And so when you see some other numbers, first thing to think of is it just something to do with the lag of I leave it at that, and please feel free.
Thank you. If I can use Chair's prerogative and then bring others in. We saw that graph of all London boroughs clearly showing us at a very, very low end in terms of impact here, and in terms of positive responses and so on. And I was on Time Radio, which is a new radio station, and introduced as the council leader with the lowest levels of infection and positive tests and so on. And just remind us why we should not in any sense take any comfort or in any sense compare ourselves favourably with our other London partners, because this is serious stuff. We're all in it together. And as you quite rightly say, just remind us once again so that we don't become complacent.
Yeah, so very wise words, Councillor Alan-Brittis, and thanks for voicing them. So London is porous. The life of Londoners is not bounded by borough. Merton residents or Merton residents live here and work elsewhere. We've got flows within other neighbouring boroughs, but we have flows across the whole of London. If you look at our schools, siblings sometimes share schools, but sometimes they go to different schools. They do go to different schools in different boroughs. And so the way Londoners live their life is not by borough boundary. I think we have some luck. There's some lag period. If I tell you today we had 10 new cases, that's quite a big jump. So today we're lucky, tomorrow we are unlucky. The main principle is that we work very closely together. And London, as the London leaders, the mayor, have agreed that London will work on the control of the coronavirus together as one, and I am very grateful, to be honest.
Thank you. Councillor Stringer.
Thank you so much, Dagmar, for those weekly reports. They're really interesting and useful. But one thing I don't quite understand, and I wonder if you can explain a bit more, is what you mean by a situation. When we talk about a situation, does that mean there's definitely been some onward transmission within the institution, or is it just that a case has been alerted to LCRC? And a related question, because lots of the situations are in schools, is what data do we have about the age of the cases being confirmed? Are they still mainly of the kind of profile that we're seeing nationally, or are we seeing any increase in younger age ranges being affected? Thank you.
Yeah, so we have got some more detailed data which we share with our internal MOCOC officer group. But as you can imagine, we're also bound by confidentiality rules, and obviously take that very seriously. So we're not sharing individual cases. We have got a profile of age range, and it is still in the younger age group. So there was quite a bit of publicity that it is very young people, teenagers and up to sort of 24. Our age range is a bit more, but it's working age mainly. And in a way it is a relief, because we obviously know that the risk of severe impact of COVID increases really extremely with age. So containing them in a way in the younger age groups in terms of harm reduction is positive. Situations is a bit of a jargon, and I think it's helpful that you pointed out we might rethink the terminology. So LCRC, which is the London Public Health Team, will alert us if necessary of settings where they even have a suspicion of an outbreak, if it's not completely confirmed, so that we are, so to speak, on the forefoot. And that is a way of monitoring. And what we are only reporting really are the confirmed clusters and outbreaks. So I take that back to our team and will amend the terminology so that it's not so jargony.
Councillor Moulton. If you can, thank you.
Yeah, I've just done it. Thank you. Thank you. And thank you for that very useful report. Just a couple of points. We're obviously now, well, hopefully everybody's downloaded their app and we're all sort of up and running in that respect. How do you see that? First question is, how do you see that affecting us all? And is that, I mean, presumably that's positive, but I don't know how the uptake is for Merton. And then secondly, in terms of the testing, part of the problem I understood is to do with the fact that they needed more tests up north. And now obviously London is looking a bit darker red than we'd hoped at this period. So are we going to see more testing here, I suppose, is my question, because obviously you pointed out that there's less testing at the moment. So thank you.
Yeah. So I think really good points, both of them. Yes to the app. Please do download the app. And if you need any motivation, Mohan has done a little inspirational video. Also, our young inspector has done a video to inspire young people. Yes, it is not the silver bullet. There aren't any silver bullets, but what we need is a variety of different interventions and tools, and it is one. So as much as you can promote the use. It is important to understand that the data are held in the phone, and so they're not shared. That was one of the big changes in a way, and it was work that people were very worried to share the data. So we do not get data fed back to us in terms of who are the people who have the app. But if they have the app, then it is their personal nudge to take their civic responsibility and duty. And that's the principle how the app works.
Thank you. Looking to others to ask a question or contribute or comment, should they so wish. I think I'd be moving. Yes, Karen Worthington. Karen.
Hello, Dagmar. I think I saw correctly on the slide that there's a difference in rates between the east and the west of the borough. I wondered whether you have any data on whether the uptake of tests is the reason behind that, and whether we've got a sort of fairly equal uptake of tests between the east and the west of the borough or not.
Yeah, so again, good question. I think understanding better the testing pattern, so who tests, home testing, you can have drive-through, there is a whole profile. We're only just getting more granular data to understand where Merton residents go for their testing, and even more where have we got where have cases who have tested positive, who are Merton residents, got their test. So a preliminary analysis is underway, and we are trying to extract key messages that we can then share with the wider Health and Wellbeing Board, because obviously, as you rightly said, what we're all trying in all our various roles is to facilitate and increase testing, and particularly the testing opportunities for people who are symptomatic. So any granular knowledge we are using for that purpose. So the moment I will know, I will share some of the key messages with you.
Any more? I want to thank Rachel Waddell for sending that video clip of our young inspector. If you all look out for it, she's chatted to us over it. Really excellent clip of a young inspector. Very proud of our young inspectors in all walks of life. Thank you for doing that, Rachel. Any other comments, questions on this aspect of our meeting? That's the situational reports, before I move on to our next aspects. Okay, we now move on to item 4B, local outbreak control briefing. Over to Dagmar again.
Hi, so sorry, that's me again. That's a bit boring. If Clarissa gives me the slide. So obviously, as Health and Wellbeing Board, we are an important part of the governance of our local outbreak control. And so the purpose of this brief slide set is to make you aware, and for us as board members to understand our roles and to understand how we work locally, how we work in our sub-region, how we work with London, and then how that all links up to the national control framework. So if you give me the first slide. This is just a very brief recap. Where do we sit as a Health and Wellbeing Board in our local governance arrangements? And if you just cast an eye, it's a bit of a busy slide, so use it as reference. I just point out the light blue, you find us as the Health and Wellbeing Board. So we are in the board that really, the particular focus for the board is to be public facing and to have the outreach into the community. And I'm glad that we've now formed a community subgroup. I'm really grateful to a number of you who also come to the subgroup. And then we've got various other community leaders and influencers who are on the subgroup to promote the engagement around outbreak control. And the chair will, in a little while, share with the board as well for approval the terms of reference for that subgroup. You will also see on the right-hand side, there's another of the light blue boxes. That is our other partnership governance structure. It is our Borough Resilience Forum that doubles up as well as our Health Protection Forum. So we have key partners like the police, the NHS, our voluntary sector, our Chamber of Commerce. And the purpose of that committee is to coordinate partner responses. There are also some bright green boxes, and that show you that Merton obviously doesn't operate in isolation. So South West London, as the sub-region, has also formed a coordination group. And then obviously we are part and parcel, as we already said, of London. If you move me on, Clarissa. I will not spend a lot of time on this slide, but just as a reminder, what local outbreak control deals with is, and Councillor Stringer, you alluded to that when we spoke about situations earlier. So In some cases, we deal with individual COVID cases where it is very, very important that even individual cases are dealt with and controlled quickly. So care homes is an example. We deal with clusters of infections, and it's quite important because the terminology can be very confusing. So clusters are two cases, positive confirmed cases in the same setting, but where we're not quite sure whether they're related. So it could be a case in a year 8 and a year 10. An outbreak are 2 or more positive confirmed cases where we are pretty sure they are linked. So let's just say 2 pupils in the same bubble. And then we have community spread, and community spread is probably one of the hardest ways to contain. It is just the insidiously creeping up of infection rates. And that's what we are seeing a lot in Merton, in Southwest London, and indeed in London generally. You will have heard that at the beginning over the summer, there were some bespoke outbreaks in certain communities. They were in a way easier to control. Hackney got quite a good control, working very closely with their Jewish community. But we have now got more widespread community transmission that is harder to get a grip on. So if you move me on. This is a very busy slide, so use it for reference mainly. But as I said, it is important to understand that we are part and parcel of the national contain framework, and the national contain framework looks at areas and looks at how many infections they have, and then they categorize them and say either we're an area of national concern, not much is happening, we're just waitful watching. But then there's areas of enhanced support, and very, very importantly, the dark green at the bottom, areas of intervention. So that are the ones where national restrictions might come in. And Merton indeed is right at the top, but you will have heard in the news, it was announced a couple of days ago, that as London has agreed and committed to go and stick together, London as a whole is now an area of national concern. So that is 1B. If we move on. This is also a busy slide, and again, use it as reference. I found it really important because it shows me how what we do in Merton links then up to what we do in the sub-region. So in Southwest London, that is the far left. So what we're doing now in the sub-region every week is that we have a so-called IMT, that it's a lot of jargon. It's our incident management team meeting across the whole sub-region with chief executives of local authorities, with NHS, with the DPHs. And we look at Outbreak, we pore over the data to understand as best as possible where we are and how we can help each other. If you move further up the ladder, I also wanted to point out that there is a London Leaders meeting. So that is the assurance that the political voice is absolutely heard and feeds into London. And you will be aware that the representative from Southwest London on the London committee is Ruth Dombey, so she's the leader of Sutton Council, and obviously Councillor Alan Brittis links up with his Southwest London leader colleagues. And then you see going step up how the regional London discussions then feed into the national decision making. So for reference, I felt this was quite a helpful slide. If you move us on. We can skip that one. So the last one, which again, I think for the Health and Wellbeing Board might be of particular interest because potential impact on our schools and educational settings of any restrictions is very close to the heart of all of us local. the national framework, Contain framework, has specified that, first of all, there's a commitment not to close schools, and that means not to use school closures as a means to control generally the infections. What can happen, and has happened in Southwest London, is that if we have a big outbreak in a school, because, for example, so many staff need to self-isolate, that school might have to close purely because it cannot function for a while. But that is different to using school closures as a means to control infection. We cannot, under the national control framework, use school closures locally as a means to control infection. It can only happen if we are in national interventions. You will remember now that busy diagram with a dark green at the bottom, and it will then get negotiated between region, which is London, and national. So I thought that was quite helpful to understand in terms of education and our school settings. I think that is the last slide. Can I just check? Yes. So hopefully that reminded us all where we sit, what our roles are, and how we need to work across sub-region, region, and national.
Thank you very much. Thank you, Dagmar. Questions, comments on this aspect of our discussions today? Yes, Mohan.
Thanks, Stephen. Thanks, Dagmar. That was a really good update of where we are at the moment. It's a kind of philosophical question, really, about do we have any data about the sort of potency of the virus at the moment in terms of strain? Are we expecting, I mean, who knows what to expect, but obviously there were some deadly strains sort of early in the year. Have we got any things around that at all?
Well, yes. Let me see, is my microphone on? Yes. So plenty of research, because obviously as COVID is a global phenomenon, the global research community is on all cylinders, I would say, but there's still a lot of learning. So the virus does mutate, like all viruses do, but it doesn't seem that there are a worsening of variants. What is classical generally in virology is the pressure, the mutation pressure is for the virus to procreate. So viruses that are very deadly end because they kill their hosts. So generally, the mutation pressure is to milder mutations. And there were some hints, particularly in some of the Chinese literature, that might happen with COVID. But there is not enough evidence yet to say, people, you can relax. Yeah, sure. The virus is getting milder.
Thank you.
Thank you. Aditi, over to you.
Thank you. Thank you, Dagmar. That was really informative. I just want to say how positive it is that we're working together as London. We know with our communities and populations that people work in different areas, they have to go across the boundaries. And I think it's really valuable that we're looking together as a whole. I appreciate that the levels of Merton are lower at the moment, but I think knowing my patients and the fact that they commute to all boroughs of London and the other way, I just want to thank you for highlighting that. So I think that's really important that we're working together.
Thank you for that. Any more contributions, questions? Yes, Doug.
Hi there, thanks. I just want to echo what everyone else has said in terms of the gratitude, Dagmar. Also, I wonder the really important point you made about the commitment not to close schools as a means to control the spread. I know that there are many parents who are very worried about potential further lockdowns and closure of schools. I wonder if there's anything in terms of messaging that might be useful to allay parental anxieties of this.
Yeah, we're working very closely, particularly with the head teachers and through the head teachers with the parents. There's both. I have come across parents who are really anxious that schools are a place where their kids can get the virus, and then they bring the virus into the family. So anxiety to say, oh my gosh, do I really want the kids in school? I think opening our schools in Merton was very positive, because we've really tried to encourage, and attendance was very good. And then there's, as you said, the opposite, that parents are now worried to say, oh my God, there's so much self-isolation going on, and the bubbles are sent home, and everybody with a sniffle is trying to self-isolate. So we're trying very hard, and I'm really grateful, Karen, you've been really helpful to get some simple protocols and explanations so that parents can, to a certain extent, distinguish what is just legitimately snuffles or a simple cold versus are there any of the three COVID symptoms. When it's all working again jointly between primary care and the schools. Equally, we had the BRF meeting where primary care was there as well as the schools, which was very helpful, because we found out, that we all struggle with the testing. So the schools, in exasperation, sent people who need a test to primary care. Primary care then sends them to pillar 2. Pillar 2 is the one that hasn't got the tests. Once we understood that our commonality is that we need to get the testing sorted rather than working against each other, that was really, really helpful. So all in all, we try very hard with the messaging. Any of you can play a really important role. So I look at Councillor Eleanor, but also wondered whether Rachel want to say anything about schools, messaging, parents.
Rachel.
I'd be glad to. So the first thing I would say is that what we're picking up from schools is that the situation is becoming quieter with them, by which I mean that as the messages that we have relayed to them with the support of the public health team have kind of been deployed in response to local situations, they're becoming more confident with the use of the advice, they're becoming more confident with the support they're receiving, and able to work with their student population well. So although the schools went back on the whole pretty well, the first cases that were identified in schools caused quite a flurry of concern. But certainly at the start of this week, we've had no further changes from last week in terms of schools contacting us and needing high levels of support and advice. So that's really positive. They are acting responsibly in line with the guidelines and with good support, both from local public health colleagues and also making good use of the DFE hotline. And we've had positive feedback from schools about the advice that they've had from there. What I would say is that some schools are suffering significantly from community concern being expressed towards them, conflicting levels of expectation. So some parents, community members and the public think schools aren't doing enough, think schools should be closing, think schools should be have different and higher levels of kind of hygiene practices over and above what the guidance requires. Conversely, some families and community members think the reverse, think that what schools have in place is too draconian, is creating too much pressure. So they are, I think, experiencing that as very challenging environment in which to work, but navigating very skillfully through it. And I'd like to pay tribute to them really for the calm way that they're working here in Merton, and tribute to the colleagues in the education division who are supporting them. And so far, it's not easy, but it's been handled well.
Thank you. Thank you for that, Rachel. Vasa, over to you. If you can unmute yourself.
Thank you, Chair. I think we must really thank our schools and our teachers and our heads. Running a school is much harder than running a practice. I work in a very controlled environment, and people come to me for a health reason, and therefore it's a different equation. Schools is a totally different playing field, and it's not a level playing field. It's not a fair playing field, and our teachers are doing a good job. And I think we really need to call it out and really thank them, because we need to look after our mental and physical health of our school teachers, our school, people who work in our schools, because this is a long-term investment in the future of our country, of our place. And I think if we sacrifice in this battle with COVID, we can't afford to obviously not sacrifice our healthcare workers, but we also can't sacrifice the schools or anybody. But really, we need to stand with them shoulder to shoulder and support them when they ask for help. Some of them will come to us with anxiety problems. Some of them will come to us with fatigue. And we must respect people's genuine fear. People don't live in isolation. They may have their own health problems. Their parents may have health problems. So there's a lot of variables here. And I think we really need to respect people's genuine fear and allay fear which is not evidence-based.
Thank you very much, Vas. I can confirm it as a council. We have the primary heads forum, the secondary heads forum. We address them regularly. We have a great relationship with our schools. And yes, we must not forget to go 6 months or a year without thanking them in any way, because the job that they do, the head teachers, the staff, the governors, is absolutely amazing job. But added to that is COVID and dealing with parents' different views of the issue is very, very difficult. Thank you for that intervention. It may be that Ellie wants just to say how we keep in with our head teachers and teachers.
Yeah, so as you said, we already had strong relationships with our heads, and that's been really tested but strengthened over the past few months. And so every head will have a Mercy education partner who's speaking to them regularly. But what we also encourage is a lot of school support. So we have kind of school clusters who are supporting each other as well. And it's not, for me, it's not just about the schools, it's about the families. The schools are then excellent spokes for their families and their communities in their area. And they play such a crucial role. And it's great to hear you thank them, Vasa, and I don't think we can thank the heads and the teaching staff and all the other support staff enough for everything that they've done.
Yeah, and this is across all the leaders within the council. Councillor Moulton is here. I know she has been a school governor, is a school governor, and councillors across the board. We're corporate governors as councillors as well. We take our duties seriously, but this is across all parties. Certainly, all the main leaders, all the leaders. Okay, we shall now. I think. Did anyone else? Karen, did you have your hand up? Okay. So I think we'll move. I know we're before 7 and Rob is here, but I think we'll still stick to the going to the NHS now, if that's all right, Rob. So I think it would be nice to get a bit of a clears. But Dave, did you want to say something?
Yeah, it was just that part of it was to approve the terms of.
Oh, yes, that's next. Yes.
Yeah, and I just wanted to add, can Healthwatch Merton be part of that membership on that? Yeah. That was what I wanted to add.
Okay. Yeah, let me go on to that first. So it's we have before us the Health and Wellbeing Board Community Subgroup Terms of Reference. There's a recommendation there for us to agree those terms of reference. We've had the agenda item 4B. Just to go through a few of, I don't know if there's a slide, but I can go through the report and the terms of reference by blocks of paragraphs. So as we know, the Health and Wellbeing Board's community subgroup is there to support the implementation of Merton's COVID-19 outbreak control plan and delivering the member-led governance board as suggested in government guidelines. The subgroup is also there to provide oversight of work in the impact of COVID-19 on vulnerable communities, especially those disproportionately impacted by the virus today. This is very, very important for our BAME community. And now we turn to the terms of reference. So we have the purpose, which is to support the implementation of Merton's local outbreak control plan. We have the Health and Wellbeing context, and this community subgroup is an advisory consultative forum and is accountable to the Merton Health and Wellbeing Board. Its responsibilities are communication, engagement, support for vulnerable people, engagement with vulnerable communities, as we said, including the BAME communities, and to review health and wellbeing services. Its principles and priorities are there to tackle health inequalities, prevention and early intervention, health in all policies approach, think family, experimental and learning, and its membership is listed there. And as we've just heard, the Merton Health Watch would like to be part of that membership. And we move on to accountability. The community subgroup is an advisory consultative forum and reports to the Health and Wellbeing Board. And operational arrangements, we have terms of reference here for frequency of meetings, duration and setting of meetings, agenda papers, transparency, quorum, and of course the code of conduct. And the duration of the community subgroup is that it will be a task and finish group and has a fixed term to April 2021. So the recommendation is that we agree these terms of reference unless can I open it up? Sorry, I'm going too fast. Any comments, questions? No, this is quite a technical paper. You've all had it. So unless I hear any dissension, is that agreed and we take on board Dave Curtis's point about Health Watch being involved? Is any dissenters? There being any dissenters? There being no dissenters, that's agreed. Thank you very much. Thank you, Dave, for I was going to go on to NHS and skip this item, but very important that we take it, and thank you for your intervention. Okay, so NHS update. I'm now happy to hand over to Mark, John, and Vasa. Over to Mark, I think, first.
Yeah, so thank you, Chair. I'm in day 6 of my job, so I will attempt to give you the overview of the health response and then hand across to John and Vasa to correct me where I've got the detail wrong. But basically, I'll take the slides as read. And actually what we are talking about here is we're often asked the question in health now, is it phase 2 or is it recovery? What are you preparing for? And the answer is both. So absolutely from a health perspective, what we want to ensure is we are now going back and recovering some of the activity that was stopped during the COVID outbreak or phase 1 of the outbreak, and also then making sure that we're preparing and lessons learned from phase 1 so that we are in preparation for any phase 2 and on the back of Dagmar's presentation. So some of the areas that we're really focusing on: discharge. So absolutely making sure that the patient can come out of hospital quickly and safely. Clinical safety is of the utmost importance, so we have to make sure whether it's back to their home or indeed back to a care home, that safety is paramount. We've put additional nursing support into special schools so that they've been able to reopen. And there's a support package through the PCN DES, the contractual mechanism, for additional support for care homes, including weekly check-ins, a clinical lead, pharmacy reviews, and also access to multidisciplinary teams. We continue with the rapid 24-hour response to try and keep people at home and safely at home. And then I think also when going on to the next slide, in our with primary care, I think I'd like to bust the myth that primary care closed during COVID. I don't think it did. Changed the way it was working. So primary care was always open and remains open, but it is looking at working in a very different way. Obviously, it's incorporated all the infection prevention control and the standard operating procedures that are needed. It continues to do face-to-face appointments where clinically appropriate, because actually we still want to make sure that it's virtual by default and that we are treating people remotely as much as possible and actually only bringing them to the practice when it's absolutely necessary. We're working with practices on their business continuity plans and keeping our same-day access pilot afloat. And all this is done in the context of flu and winter, and actually making sure that things like flu vaccinations, etc., are being carried out by practices. We're catching up on things like long-term condition reviews, cancer screening, childhood immunisation, and also in terms of inequalities, really focusing on health checks for people with learning disabilities or indeed serious mental illness. I would like to say that in terms of the slides, there's something I would like to just add around the testing conversation. And that in Southwest London, hubs have been set up in our major hospitals, including St George's and St Helier, for primary care staff and their families who are symptomatic to be tested. And that's a new development just this week, and a really important development, because I think it enables us to actually see who is positive and who needs to isolate, and it allows us to mobilize and keep our primary care clinicians at the coalface and in their practices treating patients, rather than having to self-isolate. I'll probably just pause there because I'm speaking very quickly, and hand over to John or Vasa if I have not represented us correctly. John.
Thank you. John,
will I come next? I just wanted to update the board on some of the work that we're doing around planning for the second surge in relation to hospital discharge, and of course to just update the board on our work around people that we're shielding. So as the board already know, at the start of the pandemic, there was a predicted increase in people that would be coming into hospital and then subsequently being discharged from hospital. We got very, very detailed and clear numbers from the NHS about the numbers that would be coming through on 4 different pathways from 0 to 3, ranging from people that would need no care, people that would be discharged with home care, people that would need some form of bed-based reablement, and people that would need either temporary or long-term care until we went home. So we worked with our health partners, with CLCH, to design our pathways and the system in preparation to ensure that we had capacity to meet those numbers. We are now started the work and the detailed planning on the second surge, again with the updated numbers from the NHS, along with the predicted winter planning we would normally have to do. So we're planning on both sets of numbers as we speak. At the start of the pandemic, again, those people that were extremely clinically vulnerable were asked to shield, to stay at home, to protect themselves and to protect the NHS. Initially, that was for a period of 12 weeks. But of course, it went on for a lot longer than that for a lot of people. In Merton, we had about 7,200 people that were shielding. So shielding paused on the 31st of July, I think it was. But we are ready to restart that if necessary. The role of shielding for the local authority and for health at the time, the government were providing food packages, and health in the local authority had to provide the rest, from medication through our pharmacy to support from walking dogs, emotional support, ensuring that people had the basics, the other things that weren't provided by the government. If shielding is restarted, we will also have to provide the food. So we are working with our local partners, with our supermarkets, to ensure that we've got capacity to do that. The only other thing I wanted to speak about very quickly was the impact on care homes. The panel members will know that nationally, our residents in care homes, due to their vulnerability, were impacted on at a higher level. We are planning for the next surge, and one of the things that we did at the start of the pandemic was worked with health and with the CCG to set up our care home support team. That was a team of people from nurses, led by public health, providing support to our care homes, whether it's practical support around infection control, around nurses being able to go in and provide more support to people, and as well as monitoring the infections in care homes. That team is still ongoing, and it's been commissioned until the end of the financial year. We're also working with the CCG as well to look at, I'll use hotbeds for a a term, it's not the best term, but to look at temporary places that people could go, a temporary unit that people could go when they're discharged from hospital and they're not able to go back either to their own care home because they've got a positive result, or back to the community because of a positive result, and for some reason they're not able to go back into the community. We're looking at that as a pilot that might be rolled out across all Southwest London. And that's all I had to update on. So back over to Vaz.
Thank you very much. Vaz, over to you.
Thank you. As much as schools were not built for COVID, neither were primary care premises. Speaking as a guy who works in 2 houses put together to make up one practice. So things have been challenging. I think we have to be honest about it out in the streets of primary care. We are trying to continue to work in our natural footprint. That's where we belong. That's where we are in the community. People know that we have been there for years and years. The pharmacy is around the corner, the shops are around the corner, and therefore we in primary care are doing our best with our business continuity plans to stay put. Of course, things get bad. We do have plans to buddy with the neighboring practice, to work with the PCN, but I spoke to every single GP I've spoken to says, no, I'm staying here. I will stay here as long as I can. And I think that spirit, I think, is important for the community because I think we belong there. But we have to accept the challenges of IPC have significantly impacted on our productivity. Our productivity is very, very poor. I think poor is a polite word. It's really, really hard to be productive when you have to have a waiting room which can't be full. But we have to have a waiting room which can't be full. If I am going to ask somebody with valvular heart disease and learning disability, or a baby who's only 6 weeks old, to come into my room with confidence that I'm not going to give that baby anything, I got to assure the mom that my waiting room is not full. And this double running, where I had to see people who might have mild COVID, I might have to see people with fevers, I might have to see people who are older people with diabetes, or people who might have cancer, and keep the children immunized so that they remain well for years to come. This challenge is a challenge being faced by every single practice. And I'm proud to say that the GP practices, the practice staff have all stepped up to deliver this ask. In Merton at the moment, three of my colleagues on the panel, Mohan, Karen, and Aditi, at this point in time are ringing around 22 practices, checking with them, how are you progressing with this challenge? How are you coping with this pressure of doing long-term conditions, doing learning disability, doing mental health, doing diabetes, planning your flu campaign, maybe in a marquee, maybe somewhere else you've never been before in your life. The good news is that people are following the IPC guidance, which we have to follow, and accepting that despite the low productivity, the task has to be delivered. I can go to my slides, but I thought it's better for me to speak to you from the floor as a guy who has been on the floor, so that you know what the real feeling is. Fatigue and fear are 2 words we mustn't dodge. I think we are not living in the days of the First World War when one has to be ashamed to say I'm tired or I'm scared or I'm worn out. I think we are living in a different Britain today, and we have to accept, Jen, that this is a true concept for our staff, and we have to provide and look after them, because to rebuild the nation post-COVID, we need to have these public servants in a proper state of mind. I'll stop now.
Thank you. Thank you, Vas. And that last point you made, we need to look after ourselves if we're going to look after our residents as well. So this is a message to counsellors, to leaders, to doctors, to head teachers. These are very, very difficult times. And here at Merton Council, from Jed Curran, our Chief Executive, to the directors, staff, the councillors, the cabinet, we do remind each other, please let's also take that short break, take that respite, because we need to be right and in place to help others. So thank you, Vasa, for reminding us of that. So we've had Mark, we've had John, we've had Vasa. If there are any questions or comments aimed at them, please do say whether or who you're aiming the question at, or if it's a general question to all three, or if it's a general comment. Doug, over to you.
Thank you, Chair. It's just a general comment. Just want to also point out that because of the impacts to productivity for everyone across all areas, we should also congratulate everyone for adopting new technology and new ways of working, such as this forum as an example, but also to all our clinical colleagues as well, because even though the waiting rooms may not be full physically, they are virtually increasing and booking up. So just wanted to make that point as well.
Thank you, Doug. Although I find Zoom more pressurized than a physical meeting, but yes, I think we've all caught up. Bassett, do you want to come back?
I think I gave you the piece from the primary care perspective, but I think I'll be failing in my duty if I don't give you the piece from the perspective of the hospital and also the community services. So I think our district nurses, our community nurses, they are actually in this fight with COVID. I think sometimes the TV cameras are in the hospital, in the ITU department. I think we do a disservice to the backbone. Our foot, I don't think it's impolite to call them the foot soldiers, but actually they are our soldiers on the front line in the community who go from house to house, looking after vulnerable people who probably don't see anybody else for the entire week, apart from that nurse who called. And I think we need to, they are also human beings, and therefore they are also at risk of COVID. Some of them come from the ethnicity with a higher burden. Some of them will carry the disease with a higher burden, but they still carry on working. And I think we have to thank them for that bit of work. And going back to the hospitals are also doing dual running. They're trying to diagnose cancer, they're trying to treat heart disease, but they're also trying to treat COVID. And I think the challenge of dual running, which we didn't face in March or April or May, which we are going to now face, dual running plus winter plus flu, plus COVID. I think this is an ambitious ask. It's definitely a good reason for us to ask for this ambitious ask. We can't let things go now for another year, but we need to appreciate that this is going to be challenging for everybody. And things are happening in hospital to try and make this work so that people don't get deployed to a different department and what they were doing, maybe heart failure, maybe diabetes, maybe lung disease, whatever they were doing is not sacrificed. But I don't think we must underestimate the challenge which being faced by hospitals too, to deliver this, what I call dual. It's not dual, it's quadruple.
Thank you. Thank you for that. John.
Sorry, since we're giving lots of thanks here, can I give some thanks to our care workers in our care homes? During the pandemic, our care staff are amongst the lowest paid in the whole system. They do come predominantly from the BAME community. Our care providers in Merton and our care homes in Merton continue to provide the same high quality service throughout the pandemic. We had lots of concerns about the impact on staffing during the pandemic, and I cannot fault the way that our care staff and our care homes worked to provide the same high quality services from start right till now.
Thank you. Brian.
I'm mute. It's an obvious question, really. I mean, we've mobilised and put infrastructure in for COVID, and it's absorbing huge numbers of resources. My concern is that patently we have run down completely, and it's a mark, really. The business as usual, as we mentioned cancer screening, we've mentioned other elective services that are not being run. At what level have we remobilised, Mark?
So just to say that all our hospitals have submitted trajectories of improvement back to 100%, back to kind of pre-COVID levels. And that's a very ambitious aim between now and the end of October. So we are anticipating that we're asking them to go back to usual activity levels, and also then in addition to that, look at backlogs. I know that lots of secondary care are looking to primary care for support around some of the referrals into secondary care, and we are working, and I think one of the silver linings is that we are across the priority kind of pathways such as cardiology or diabetes, etc., what we are seeing is secondary clinicians and primary care clinicians really coming together to work on the end-to-end pathway for patients. I would also just add that in terms of going back to Vasa's comments, it really is important that we address the inequalities here and any perpetuated inequalities that COVID may have kind of emerged from COVID. And so therefore things like our diabetes work, our childhood IMS work, our working with learning disabilities needs to be really at the forefront of everything we do. But your question, it is back to usual, really, as soon as possible.
Thank you. You had your hand up, Mark. Have I think you've used that.
I've used it. Yeah.
Thank you. Una, over to you. Did you want to have a word, Una? No? Okay. Any more questions or comments before we move on to our next item? Can I thank Mark, John and Vasa for the empathy and feel and sense of belonging to the community and to the patients, to care workers, and to the great relationship that council has with care homes. Thanks to John, and I know Hannah Doody is here as well. Thank you to everyone. Care homes are very, very important to us all. We'll now move on to that item that we pushed up. So I'm going to hand over back to Dagmar. Welcome Simon Shimmons from MVSC and Rob Clark from Age UK. Over to whoever is first. I think it's Dagmar.
Yeah, so from me, just a very brief introduction. So this session is about what we are about as a Health and Wellbeing Board, more than anything else, engaging with the community to protect them and to work with them to protect others. So as the potted version, for us engagement, what we mean is a two-way dialogue. So there is a lot of listening in all humility to really understand what was the lived experience. A number of you have already pointed out, we are now clear that the lived experience, the impact of COVID was very differential and hitting different communities, different occupations, different households very differently. We need to understand, and we are committed to listen to the lived experience and then use our engagement for messaging. And that is around promoting the prevention messages and the protection messages about COVID. And obviously the two hang together. Only if we understand what the lived experience is like, can we tailor the messages so that the community trusts us. And underpinned the approach really is an asset approach. It's a bit of jargon, but what we mean is that we go with the strength of our communities, their own creativity, their own solutions, and that we are aware that around COVID protection, there is a lot of limelight often on the enforcement, and sometimes enforcement, of course, is important, but the biggest importance is that we are engaging the community and the community works with us for the solutions. So there is the 3 slides give you a little bit of an overview. I won't dwell because I would like to invite next Simon and Rob to give a little bit more details of what is actually happening.
Thank you. Simon, over to you. Are you there, Simon?
It looks like Simon's been bumped from the list, actually.
Okay, Rob, do you want to?
Yeah, I can. I think Simon was going to give an overview of the community response through this slide here, and I think in many ways those numbers speak for themselves. A lot of them relate to the community response hub itself, which I'm going to talk about in a little bit more detail anyway. But one of the things I think Simon would be keen to highlight is around that £199,000 worth of funding awarded to 71 local organisations through the Merton Giving Coronavirus Fund. And so obviously that is small grants, very grassroots led, that recognise the huge amount of flexibility, dedication and commitment that's been provided by primarily smaller organisations to support their communities. And I think that's something that we need to acknowledge, and also pay tribute to all of the partners that have put money into that pot to allow MBSC to distribute those funds in that way. If we can go on to the next slide. Yeah, so I guess what I wanted to do really with this slot is to present a little bit more information and detail about the community response. And as the board will know, the Community Response Hub itself was taken on board by the voluntary sector, MVSC, AGK, Merton and Wimbledon Guild from July onwards. And up to, from that point, July to September, the hub has continued to be, I guess, a central point of contact for the public primarily, to seek advice, support, information and additional kind of help with COVID specific issues. And what we've found is that the majority of calls that have come through to the hub have been kind of tier 1. So people seeking information, clarity over the guidance, which we know has changed a number of times and perhaps hasn't necessarily been the most clear, but getting clarity from a person on the end of the phone saying this is what it means and this is how it impacts on you and your personal circumstances has been, I think, an incredibly valuable thing to provide for local residents. The 20% there at tier 2 is around short-term practical support. So these are the sorts of things that we were provided at the peak of the virus, around shopping support, emergency food parcels, help to get prescriptions, and telephone support, befriending effectively for people who were feeling particularly isolated as a result. And then an additional thing that we added in on taking on the hub was around more complex casework and ongoing support. So support for residents who had more complicated issues that needed unpicking and supporting over a longer period. So as you can see, the primary driver for people calling has been just clarity, trying to get clarity and some practical support to help them with the immediate issues that they're facing, that COVID has thrown up for them. Those numbers aren't as high as they were in the peak of the crisis, but at the same time, partners across the whole of the voluntary sector have been providing that ongoing community response. And so I wanted to draw attention to the fact that, and this is the data that I'm able to access in terms of AGK, Wimbledon Guild and MVSC, but 1,500 residents are receiving regular practical and emotional support by those 3 organisations alone. And that really gives you an indication that community response is way more than just the community response hub. It goes bigger, deeper than that, and there's so much activity that's happening at neighbourhood level even to support residents to kind of get through this. And so that large-scale community response across the VCS continues, and as Dagmar alluded to there, we and lots of voluntary sector partners have been doing specific engagement work with specific communities to try and help people understand the guidance and to provide reassurance around outbreak control, and to make sure that people are aware of the support that's available to them. And I think as we move forwards, we'll need to continue to do that on ever more targeted levels with communities who may be more difficult to reach or perhaps finding it harder to understand some of the kind of guidance that's out there. One thing I would flag, and I think we've all alluded to this, and Vasa made the point very well, is that, you know, we've been doing this for 6 months now. We've all been doing this for 6 months and beyond. And actually the adrenaline that was in the system and in people to begin with to respond to that initial need kind of needs to be continued, I suppose. We need to make sure that people are supported and that the capacity is there to cope with that demand. And in that, we also need to ensure that we've got good numbers of volunteers within the community to kind of continue to provide that future response if the situation changes and lockdown restrictions increase again, which could present problems for our residents. Next slide, please. But what I wanted to do primarily really is kind of, without distracting from the immediacy of the COVID response, is highlight some of the issues that we feel are there for older adults by way of kind of side effects of COVID, if you will. And I think with this, I'd like us to think as much as we can about the kind of long-term health and well-being needs of our residents, as well as that kind of immediate direct impact. So these are not issues that are specific to older people. I would say that a number of the things I'm about to talk about are likely to be experienced by people of all ages. We've heard about children, schools and families and anxieties and complications and challenges there. And I think some of the things that I'm going to talk about with older adults are absolutely present regardless of how old you are. But I also think there are some specific issues in there that, you know, we as an organisation at Age UK are able to lend some insight into that lived experience. So in terms of Age UK and our numbers, I think the numbers there sort of speak for themselves to a certain degree in terms of increased demand. People who were happily going along with their lives and able to kind of live very independently without needing any particular additional support have been thrown by COVID and have needed that additional support, either from us or from elsewhere in the VCS. And I'm sure my colleagues across the voluntary sector who work for other organisations that support older adults would also say that they've experienced numbers of this scale. We at Age UK have seen a slight demographic shift, so a 4% increase in clients accessing our services from BAME communities. And like I said just there, people who perhaps were fine for the most part, under 65 potentially, those sorts of things, we've seen an increase in people needing support from those ages as well. And as we know, the health inequalities within Merton, for us, we are based in the East, so you would always expect Age UK to have a certain heightened numbers in the East, but 65-35 in terms of our client base over the last 6 months does tell a very clear story in terms of where some of those needs are. And I've drawn a horrible crude line across the borough there, and you will forgive me for that, council team. The thing I wanted to talk about more comes onto the next slide, which is around the lived experience. So we know, and colleagues have obviously reflected on this, that there's significant direct impact and risks of more severe outcomes from contracting COVID for specific communities, and then even higher if you look at it with an intersectional lens. So looking at someone as a whole in terms of you know, all of the kind of elements of that person as opposed to just they're an older person. But I think what we're seeing and what we've seen over the last 6 months and what gives us cause for concern for the next 6 months as we go into winter, which is known to be a more challenging time for older people, is that kind of indirect impact, which I think I kind of alluded to at the last board meeting. So the kind of worry for us, and I think colleagues will share this, is that there's that long, sharp sting, I'm calling it. I'm not quite sure whether that's the right way to look at it, but around that mental and physical well-being because of those indirect impacts. And we know that things like shielding and self-isolation are probably the best solution that we've got at the moment to protect people from COVID, but they do have side effects. And we have to kind of think longer term about how we address some of those issues and support people through that period of self-isolation and the difficult period, so that we can come out of it with as kind of lower impact on people's broader mental and physical well-being as possible. So we have done a piece of work based around this lived experience through our staff team and volunteers, which has sought to kind of assess some of the themes and issues that our more regular clients are presenting to us about the issues that they're facing. And I've broadly categorized them. And the first one is around social connection and mental well-being. So as I mentioned there, that self-isolation and shielding kind of concept has increased loneliness. There's no way of getting around it. It's the best solution we've had at the time, but it does put people into positions where they might be spending a hell of a lot more time on their own. And we already know about the health impacts of loneliness and isolation. And in so doing that, the knock-on impact of that we're seeing is a decrease in confidence. In many cases with our older adults, in particular, reduced cognition, so an acceleration of cognitive issues and things like dementia. We've definitely found that lack of connection has really accelerated some people's dementia. And in some cases, as a result of that isolation and the loneliness, cases of self-neglect. And then for other people, and I think others will see this in working age adults as well, just that level of anxiety and tension around the issue of COVID itself, but also kind of that isolation and not being able to get out and about and live your normal life kind of creates that fear that is very prevalent in a lot of the people that we're supporting. And then kind of the knock-on kind of end result of all of that really is an experience of low mood. And in some cases, I'm sad to say that a number of our clients are feeling incredibly desperate, and we've had calls from some of our regulars that they just can't go on anymore. So that suicidal ideation is present, which is obviously very sad and difficult for us to kind of deal with. Next slide. And then in terms of physical health, again, some of the kind of knock-on impact of that isolation is that there are barriers around access to key community and health services. And I'm really glad to hear that NHS colleagues have plans in place to kind of recover services to full capacity. I think that will help. But I think that the short-term issues around people not being able to kind of access certain services through no fault of those services has had an impact. And from a community perspective, a lot of what voluntary sector provides for older people is access to physical activity. And so as a result of that, we're seeing in many cases pronounced deterioration in physical health because people just aren't moving as much as they were. And that in and of itself, like the social isolation, does have an impact on that reduced confidence. The mobility aspects of it, the kind of core strength and stability that we hope to maintain with some of our physical activity programs is unfortunately deteriorating. And that does result in increased frailty and the increased risk of falls. And again, the kind of risk of extended periods without those underlying health issues being addressed is a factor. And we've certainly found that people have ceased to proactively manage their health conditions. And I think health colleagues would probably endorse that. Lots of the ways in which people were able to kind of manage their conditions through physical activity or connection or accessing services over that kind of early period have not been there. And I think that is having a result in that. And that comes back to that connection, those established routines that help people to manage those health conditions has resulted in people really losing some motivation. And then just coming on to kind of a wider socio-economic determinant of health around money and finance, but I speak for sort of colleagues in places like Citizens Advice around this particular issue, but many working adults losing income through loss of work does present significant health and well-being implications, as we know, and some of our clients have reported negative impact on pension returns. So people's free money to do things with, to heat their homes, all these sorts of things, unfortunately, is looking a little bit more precarious. And then a specific issue that we've experienced at Age UK around, and it comes back to that access to service element of it, is that there's a lower return in benefit uptake, particularly a benefit like attendance allowance, which is non-means tested and for people who have high health needs. And actually us not being able to get to them or not them not being able to get to us has resulted in fewer people being able to apply for that. But we've worked on a few workarounds for that to kind of address that issue, but there will be a knock-on impact, I fear. And then Simon is probably a little bit better placed to talk about food insecurity and food poverty because of his role within the food network. But we know that more people are accessing food banks, and there are concerns around increasing food poverty due to the loss of income from work. And then the final thing around this, and it is not purely related to finance, but I was struggling to know exactly where to put it within this lived experience kind of feed sort of summary here, is around that access to digital. So we've talked about it before around access to services moving more and more to that virtual, and uptake of that I think is very mixed across the older adult population, not just because of finances, but because of skills and confidence and a variety of other reasons. But I think there is an impact of that too. Next slide. So I didn't want to come with a whole load of stark realities about the lived experience without also talking about some solutions that we in the voluntary sector and with partners across the system are working on. And I think it's something that I guess the ask is that we keep this in mind, that indirect impact. We need to obviously address the community response through extensive community partnership working across the system. Do as much as we can to prepare and prevent higher needs materializing if lockdown restrictions return and people are struggling to access the basic needs. And then the work that I talked about there around outbreak control and community engagement. But from a kind of longer term view, trying to take as much of that sting out of the tail of the kind of side effects of COVID, are around really trying to, for us at AGK, and I can only really talk about what we're doing, but redoubling our efforts to provide that meaningful social connection as much as we possibly can through telephone calls, through garden gate visits, through home visits where it's safe to do so, those sorts of things, because I think those little things are going to make a huge difference to people who are particularly vulnerable and particularly isolated. And we've introduced a number of things at Age UK to try and, I say, distract people, but to keep them busy really, and to give them things to keep them occupied, and some sort of motivational work to reassure them that there is light at the end of the tunnel, and there will be a better way of dealing with the direct impact of COVID, and therefore the indirect impact will hopefully reduce. And we're looking at to address some of the issues around the direct support, increasing capacity in our advanced navigation services, providing more practical support for people to access benefits or receive domestic support to help maintain their independence, moving as much as we can to promote and enable the active aging piece to keep people as active as we possibly can. And then a point here that I think is a reflection on what a lot of other people have said around that workforce well-being, and I count our volunteers and our workforce as much as anyone really, and making sure that we look after ourselves and we look after our teams so that they can provide support to the more vulnerable people that we support. And I think that's it.
Thank you. Thank you, Rob. And can I ask Simon, do you want to come in? I know something packed up just when you were raring to go. Please, if Clarissa can bring back Simon's slide, which is the one-pager on Merton COVID Community Response Hub, then I know that Rob made a good fist of representing you, but as you're here now, please do go ahead.
Yeah, thank you, Chair, and apologies. It's one of those perfect moments for your internet to drop your Zoom call, but I was really felt I was doing a bit of a warm-up act for Rob, so this is going to feel the wrong way round, but I was going to be very brief and just summarise in a way the success of the hub up until the point that Rob's sort of given more detail on what we've learned so far. And I just wanted to very briefly summarise, you know, what the combination of CCG, LBM, Voluntary Sector Health Watch, and other organisations in the voluntary sector all pulling together, Age UK, Wimbledon Guild, Common Side, Fish and others, to make a success of it in those sort of probably somewhat forgotten days of 23rd of March when we set the hub up. But just to very quickly summarise, in the period up until it moved to the voluntary sector version that Rob has given a bit more detail on currently, we logged nearly 2,000 individual contacts, and 62% of those were from residents seeking help for themselves. And also positively, the other 38 were from parents, neighbours, or family members seeking to get them their support. A couple of other highlights that were so helpful is that the prescription demand, which was there at the outset, the social prescribing team that MBSC run were able to support that. And again, we had so many offers of help from local volunteers, in addition to the circa 3,000 from Mutual Aid Group and Wimbledon Dons and the like. And that related very much to the number of emergency care packages that were delivered to households, the 585. The bottom left-hand corner, just to summarise, we did today just close what we call in the first phase of the Merton Giving Coronavirus Fund, and the total figure is £210,640, which has gone to 75 organisations. And again, a very collaborative both pot of funding and an impressive set of panel members who have achieved weekly panels to provide that level of support. I think it was Mark mentioned earlier about sort of lessons learned, and I think the point I just wanted to make as a lead into the details that Rob has now gone through was that although there was huge success in running the hub during that period, we have realised that we haven't reached certain communities and certain residents, not from lack of trying and communication, but that they haven't come towards us. And I just wanted to let the board members know that that's an ongoing agenda that we're trying to improve as we continue the work of the hub. I think it also has shown how strong, not just the voluntary sector, but the way it works so positively with the borough organisations and the health and London Borough Merton teams produce such a success. And the bit I certainly say to my team is, if my takeaway is that the whole attitude around supporting, particularly vulnerable residents was the answer's yes, what's the question? And I think that's the sort of collective attitude that the voluntary sector and the statutory sector organisations have made a success of it. So sorry, that was a bit a reverse warm up to what Rob went on to the detail, but I hope that helps. Thank you, Chair.
Yes, very helpful. Thank you, Simon. Pleased that you're here with us. Thank you for what you're doing with MBSC, and thank you with the way in which from March the 23rd you delivered on the hub, and thank you for your appreciation of the staff here at the London Borough of Merton, but also our GPs, the NHS, and all the organisations. It is really all about partnership. So we've had a session there with Dagmar starting off with engaging with communities, all about listening there. Rob informed us about isolation, about helping the elderly, but also about how 3 organisations, MBSC, Wimbledon Guild and Age UK Merton, have helped over 1,500 people. And then finally, Simon has informed us of that Merton a giving fund now at 210,000 to 75 organisations. and the work that the MVSC Hub are doing, but that there are still hard to reach people out there that we want to reach. And perhaps we need to ask the question for them, could be the answer, as it were. So any questions, comments to Dagmar, Rob, or Simon, please say who you're addressing them to. But obviously, if it's a general comment for all three, say so. But if it's a general comment anyway, if you can say so again. Thank you to all three. And it's now open for questions, comments. Yes, Mohan.
Thank you, Rob. Thank you, Simon. And you know, fantastic to see that piece of work. And I think the MVSC Voluntary Hub is actually an envy from other boroughs. When in some of the work I've been doing, and I tell them about what's going on in Merton, they're gobsmacked, and it really does bode well. And it's a really good infrastructure on what to build. I think the tier 1 information, Rob, which you said about that being the majority of work we're seeing, is also seen in healthcare as well. There's so much anxiety out there. And I think our collaboration in terms of getting the message across to our patients, to our clinicians, and actually to counsellors, and to everyone actually, is actually going to get us through this. And I think we're nicely in a good place for that. So I think when things do ramp up, we're in a good place. And I talk about some of those other partnerships. So we've been using Merton Mutual Aid to drop off saturation probes on a healthcare basis. And also the Dons have been dropping off PPE to all the practices in Merton. That wouldn't have happened in other places. I know it's not happening. So these are two really good examples of collaborative working. So I'm really pleased. And I think we, as much as some of the stuff we said, Rob, about people being isolated and frailty getting worse, that's reflective across the country. But I think in Merton, because of all those partnerships and collaborative working, I think we're nicely set to try and do as best we can. So well done, everyone. Thank you.
And I move to Vasa.
Yes, to carry on echoing Mohan's thoughts on this, and I think what we really shook me and made me quite emotional was the response of the volunteers, because there were here a group of people who were not paid to do something. I'm paid to do my work, so I had to turn up anyway. But here there are people who were not paid to turn up, but who did turn up, and who visited people's homes and went beyond what would expect the people to do. And I think really showed us that the community spirit is alive and well in Merton. And I think anything the next 6 months, which I will call upon the most, would be the same spirit once again, because this time round it'll be colder, it'll be darker, it'll be wetter, and people will be fatigued. And still, we need you to call on them. And I'm really please help us, because we need you more than we needed you in March. The second thing I want us to remember is the difference between digital divide and digital poverty. I suffer from digital divide, and I'm going to wait till the weekend till the daughter arrives home to sort the computer out for me. That is different to digital poverty, where no daughter can sort it out because the house doesn't have internet and doesn't have a smartphone. And I think we need to try and work this out. I think the challenge is using our school children, who almost all of them have got smartphones. I don't know how we do this, but we need to empower the youngsters to somehow reach out to the houses which do not have a smartphone and provide that connection. It's not just talking, but music. A picture of a daffodil or a tulip in the middle of December does wonders for my brain. I'm sure it does wonders for other people's brains too. And I think we really need to somehow keep the hope of spring alive during the days of December, January, February. We really have to show them that the daffodils will bloom and the tulips will come out and the nightingales will sing again. And I think we really have to focus on this. And I really look forward to the schools and the youngsters, I call them, to try and overcome this concept of digital poverty.
Thank you very much for that. Over to Rachel.
Just in that specific context, wanted to mention some good news, which is that we have, like all other local authority areas, there's been an allocation of access to more laptops for young people who don't have those resources at home. Schools are now able to access those directly, and we pass the information to schools to enable that to happen. So there is ongoing support for young people to be able to have digital connectivity that naturally supports them in their learning and their wider well-being. But if the home is without that kind of access, then it supports the wider household too.
Yes, and there is the Kids Connected programme as well. Thank you for that. and yeah, being positive is important as we enter the long evenings, the short days. Vasa, your images of daffodils do work. An image of Fulham winning a football match works for me. That'll do me. But Vasa, you really painted a nice picture there, and we need to have intergenerational connectivity as well. Any more questions, comments before we move on to the next item, which is a story, I understand. So shall we move on? We are on time. It's just 5 to 8, and we're 5 minutes early on our last item, and that is a Merton story outline framework. I've shot through the slides, really exciting stuff, and over to Dagmar.
Yeah, so thank you. So maybe it's a little bit of a misleading title. Just as a reminder, I'm going to talk about the Merton story, which is the slightly nicer name for our summary JSNA, which is a mouthful of jargon, Joint Strategic Needs Assessment. And if you give me the next slide, Clarissa, just as a reminder, the Health and Wellbeing Board has a statutory duty to produce a Joint Strategic Needs Assessment. And as you hopefully will be aware, there are a whole suite of products around data about Merton as a place and its people. And the Merton story is just one of the products. It is the sort of strategic summary that is particularly important, I think, for the Health and Wellbeing Board, because we in a way own it. It is meant to give some common understanding for all partners in this partnership what Merton is like and what are our challenges as well as our assets. And what I just wanted to make sure is that sometimes there is a misunderstanding. So the JSNA is like a profile describing epidemiology, patterns of risk factors, but also protective factors, disease and death. It is not an in-depth sort of catalogue of healthcare utilization and performance. So we work very closely with our NHS partners, and sometimes we do deep dive needs assessments when we do look very closely at services and service provision. But the overarching strategic needs assessment is the overarching profile. And we need to think as a board what and how we want to fulfill our duty and how we want our Merton story to look like for next year. And that's what I'm talking about. If you give me the next slide. So this is a reminder how we've done it before, and that is under your leadership. The Merton story runs on the left-hand side. It acknowledges that it's actually a good borough. You know, we've got lots of good things going for us. And then it lists the 5 headings as our main challenges. And all of us today have alluded to inequalities, importance of healthy lifestyles, emotional well-being, children and family resilience, vulnerability, the increasingly complex needs and multimorbidity, as well as we also have a heading called hidden harms and emerging issues. So you will remember that is how we structure the Merton story. And then there's quite a big document with key messages. And then there's this summary document for sort of very quick reference. If you give me the next slide. And the next one, that was just as a reminder for you. So what we're proposing for 2020, so for our next story, in fact, it will be 2021, apologies there. Obviously, we can't escape, although sometimes it feels like, couldn't we escape and not do COVID? But of course we can't, because the health and well-being of our people has been so much influenced. So we want to look at the COVID impact, but very much responding to what Rob as well described, that Obviously, in the first wave and still now, when you hear me talking, it's all around the direct impact. How many infections, how many positive tests, who are they? And then hospital admissions, GP interactions. But actually, the full impact is the indirect impact. It's the impact, what I sometimes call the collateral damage, the side effects that we are causing while we want to protect people. We propose that we use the overall structure and format that we are used to. People are now knowing a bit how the story flows, and we've tried it out with really big numbers of partners, whether the structures make sense. So for simplicity, we suggest to stick to that. We will update, obviously, sections. And then what is in a way new, because we responded to a discussion we had with you a little while ago, is that we want to focus our key messages and combine a bit more the stuff, the key messages that we draw from the data with the lived experience. And we have now really got the rich material. So the work that the voluntary sector is doing for us, the work that is still outstanding. BAME Voice is doing work for us about lived experience for this particular population group. So we want to draw those and bring them together a little bit more to triangulate in a way the key messages. If you give me the next slide. And then our sort of proposed process and timeline. It's important that the key messages make sense to a variety of partners, including obviously you and your organization. So we will go out and check them out. And quite sort of, if COVID allows us, in a way, we think end of January we will bring a draft to you, and then the idea is that by the end of the financial year, beginning of April, if everything goes smoothly, we will have the final version. So next slide. So what I'm asking the board is whether they are happy format suggested to stick to our known headings, whether they think process and timelines make sense, and there is a little asterisk. So you need to give me a little bit of leeway in case we become very, very busy over the winter, it might slip. And then obviously we're very keen that the Merton story really is the story of the whole board rather than the public health team. So if you could commit that we can work with your organizations to check out the key messages. Thank you.
Okay, thank you, Dagmar, for that. We'll come back to the recommendations, but let's open it up for discussion or comments or questions that people may have. Yes, Simon.
Yeah, thanks, Dagmar. The thought I had was what Mohan mentioned earlier about some of the successes that have come out of dealing with the COVID pandemic in the borough, and the the SATs testing that volunteers supported, that was an additional support to GPs. And I know I believe some health colleagues are looking at innovations that can become business as usual, possibly after the pandemic, because I do wonder if when we get to April next year, that replaying the pandemic, which everybody will certainly be very tired and weary of, we should try and do the Vassar's tulip thing of bring the sunshine that came out of quite a difficult period. So I just suggest that could be a theme of how we try and summarize some of the successes through this period. Thank you, Chair.
Thank you. Any more comments, questions? Vassar.
Mohan, you want to go first, Mohan?
Vassar.
Okay. Thank you, Chair. I think we must thank Dagmar for her usual solid, dependable, facts and data-based, evidence-based approach to everything. And in COVID, the real Dagmar comes out in COVID, and there is no bias in Dagmar's work, and she gives you the facts as they are, and she keeps us, I think, well disciplined and keeps us on the straight. Otherwise, we can get diverted into our hobby horses, and Dagmar always ensures that there's nothing hobbyist about evidence-based public health. And I think the story here is that all what we know, our previous problems, they still continue. In fact, they are aggravated by COVID. And I think even if we didn't focus our minds before, COVID has told us, focus your minds on the inequalities. And on top of the existing inequalities, it added the digital one in there, because the new reset is going to be a digital world. Whether you like it or not, I like it or not, doesn't matter. It is going to become more digitalized, and therefore we need to be digitalized, become more efficient, thereby creating the bandwidth, the capacity to deal with those who can't become digitalized. I think there should be no tension into the new normal, where the new normal actually enables us to deal with some of the stuff we couldn't deal with before because we're all saying we're too busy to deal with that. But I think that is where the smartness comes in, come March and April, how we solve this conundrum. Just like oxygen saturation, there are a lot of stuff we could do with self-care and self-management. And I think if you look at the scheme of things, for somebody with heart problems or breathing problems, that 25-pound gadget is not high cost. That's like 1 month worth of some medications I prescribe. So we should actually leave that behind in the house. In the end, the new health service I envisage will be a health service where people who need a saturation monitor have their own, and that will be part of their self-care plan. And I think that way we will enhance more self-management, self-care, and we'll create the space and the capacity to deal with the inequalities which we definitely have to deal with.
Thank you, Mohan.
Yeah, it was just carrying on from what Simon was saying, also what Basta was saying as well. And I think we used saturation probes for the volunteers during the COVID, and now we've got an infrastructure of volunteers which are embedded around some of the practices, and we used them the weekend just gone, helping us with a flu clinic at Commonside. And that was wonderful, and they were doing crowd control, and actually they could also be utilised to support residents for going for walks, community connectors, some of the stuff which Barry's doing as well in terms of getting community champions. And I think that really is how we can embed some of those hard to reach, or some of those individuals who really do need connecting, to get them out and about, certainly with a lot of the lunch clubs closing their doors. So I think it's kind of accumulating all that, and that is certainly some of the success we've got in Merton. So that was just what I wanted to add. Thanks.
Thank you. Any more contributions? Doug?
Thank you, Chair. Just to say, I've always found the Merton story incredibly helpful, and as Vasa said, it does always strike me as the differences and the inequalities that exist. I'm also struck by Rob's discussion and comments about the financial impact, especially as we move forwards, and how that could be quite a pressing issue for the Merton story, and something that can help us use as a predictor of where to focus our efforts, along with what Vasa and Mark were talking about with regards to the at-risk cohorts, for those involved with prehabilitation or those who are likely to be more impacted by the COVID. And I do recall, I think it was 1.5 years ago or so, at one of our Health and Wellbeing Board leadership meetings, not to forget the environment. And even though all this may be going on, there are still issues with regards to the environment that are still going on as well. So that's just something else that strikes me as something we've discussed before, which we consider important.
Thank you. Vasa, did you want to come back?
Dagmar, thank you, Chair. The only group of people we haven't mentioned so far is the increasing number of people we are recognizing as long COVID. And I think we need to talk about long COVID because we need to legitimize it. Because if we don't talk about it, people don't realize it exists. It definitely exists. And I think we owe it to them to mention it so that people who have symptoms are able to come out and talk about it. And then we can put in the right service for them, point them towards the volunteers, point them towards psychology, point them towards physiotherapy, point them towards rehabilitation, point them wherever we have to point them. But we won't point them if they don't come out. And I think they don't get enough mention in the newsreels, and I think we owe it to them.
Okay. Yeah, no, we can certainly put that into the system. Dagmar's just acknowledged that. Thank you, Bas. Any more questions, comments before we go to our recommendations? Okay, I think we're at the stage where we go to our recommendations, and that is, unless I hear any dissenters, we're agreeing to the format of the Merton story. We're agreeing to the process and timeline for this year's Merton story 2020, with the proviso that this may be elongated if there's a second wave, and we're agreeing to commit our organisations to work with the public health team as necessary. Are there any dissenters to those recommendations? There being no dissenters, those recommendations are agreed. We're at 8:10. I'm asked here to close the meeting unless there are any other business or anyone wants to add something. I am in the position now to thank everyone for their attendance and to say goodbye and to close this meeting. And in particular, thank you to the doctors who have allocated their precious time, and to my directors and to everyone. Thank you very much. Bye-bye.
Bye-bye.